The following podcast is part of a certified educational activity titled Hope on the Horizon in Gastric Cancer, Breakthroughs in Personalized Care with Immunotherapy and Targeted Strategies. Access the entire activity and complete the post-test at peerview.com/EHA860. Downloadable slides and practice aids are also available.
Good evening, and happy to be here with some of my colleagues who I'll introduce in a moment. This is a PeerView Live program called Hope on the Horizon in Gastric Cancer, Breakthroughs in Personalized Care with Immunotherapy and Targeted Strategies. Hey, my name is Zev Weinberg from UCLA. I'm very pleased to be joined with my two distinguished colleagues, Yelena Janjigian from Memorial Sloan Kettering and Professor Markus Moeller from Germany. We want to thank. So the goals for today are really to both enhance our knowledge with respect to the clinical trial evidence and the data sets in gastric cancer and GEJ adenocarcinomas, think about personalized treatment plans for our patients moving forward, provide case-based construct, team-based approaches to think about the disease, both management of toxicities and clinical decision-making. I will start by talking about the first part, opportunities for oncology clinicians to generate change. We're always looking to be agents of change in this disease, and we think like we've made a lot of progress over the last 10 years. So one of the things that we've realized is that there's still not enough patients being treated in frontline. If you look at electronic health records data from the United States, at least, there are about 3,000 patients who were looked at, and about a quarter of them didn't receive any treatment at all, which means a quarter of them essentially did not receive any palliative therapy, which is still a high and unacceptable number in most of our opinions. Not that every patient should get it, but certainly we want to decrease that number as much as possible. Of the patients who did receive treatment, about half received second-line therapy, and less than 20% received third-line therapy. And based on a Flatiron Health database of about 3,000 patients with the disease, this really confirms some of those statistics. So the future is changing. It continues to evolve. There's obviously all sorts of immunotherapy strategies, which we'll talk about in this disease, primarily in advanced setting, but now moving their way to earlier lines, as we'll talk about. And of course, Claudin 18.2, which is one of our premier targets in the disease. There's, of course, a number of other targets as well. So this slide's a little confusing, but essentially what we're trying to show here is that there's a number of biomarkers, some of which are maybe not representing the true frequency of that biomarker, but in fact, for example, HER2, which is the most common alteration in the disease, probably represents 15 to 20% of patients. A high percentage of patients have some degree of PD-L1 expression, up to 80 to 90% of patients with advanced disease. MSI high probably represents somewhere around 5 to 7% of patients with advanced disease. And Claudin 18.2 represents 30 to 35% of patients using the approved cutoff in the IHC diagnostic. There's a number of other emerging biomarkers, such as FGFR2 and others, but the point of this slide is really to show that a lot of this is overlapping. There are all sorts of overlaps between a lot of these biomarkers. We're just at the beginning of trying to figure out what that overlap is. All sorts of questions come up about what's the best test to order, particularly to look at MSI high. I think most people are coalescing around the value of IHC, which is quick, easy, and simple, really assigns a 90% probability, if not greater, to determine MMR deficiency, which correlates, of course, with MSI high. Nowadays, a lot of high academic centers are using NGS. We moved away from PCR because it takes a little longer and is a little less simple to do. You need normal tissue. So what practice-changing things have we seen in this disease? Obviously, we've made significant improvements in overall survival with this disease. Primarily, most of our drugs have been in front line. We have a number of immunotherapy approvals in this cancer. Many of my colleagues here have led some of these trials to bring us to the point where we are today, with both PD-1 inhibitors like nivolumab, pembrolizumab, and PD-L1 inhibitors as well. And of course, combinations of trastuzumab, chemotherapy, and pembrolizumab, and zolbetuximab and chemotherapy for Claudin 18.2 positive disease. So we've got a lot at our disposal, but still a lot more is needed, of course. So the first to start by, before we get to the case, having Professor Markus Moeller talk about immunotherapy in the disease, in advanced stage.
Thank you very much, Zef, Jelena. It's really my pleasure to be with you again here. I remember I was here last year, and at that time we did not have the approval for zolbetuximab and not for tislelizumab. So it really, the armamentarium is increasing quite a bit for our patients. Now, sorry, this one. We do have one patient, Jeremy, aged 58 years, with stage 4 junction cancer, mild dysphagia for 5 months, and he lost 5 kilograms in the last months. His PCP requested a gastroscopy, which showed a mass at the junction, at the cardia. Biopsy showed poorly differentiated adenocarcinoma with thickened ring cells. The CTs showed 2 liver lesions. Please remember, 2 liver lesions only, not more. A large lymph node at the gastrohepatic area and a thickened cardiac area. So the question, of course, is what additional information and testing is needed to help predict outcome and guide the treatment selection for these patients? Maybe you give your feedback on that? Any comments?
So, I mean, I think nowadays we acknowledge, even though there's 2 liver lesions, this still represents metastatic disease, and we really want a full complement of IHC diagnostics. So all the basic stuff, MMR, PD-L1, HER2, Claudin 18.2. That gives us, you know, even if you don't know exactly what the right thing is, you want to get that data up front in those patients.
Right. Any other comments? So, exactly, you are absolutely right. The patient was tested by immunohistochemistry for HER2. He was HER2 negative. Then we also did the PD-L1 CPS testing, which was 11. Patient had MS microsatellite stable tumor, TMB of 5, P53 mutation, and Claudin 18.2 negative. And patients did not have any contradiction for immunotherapy. So, of course, the question is now, what does the evidence say about how we should approach treatment selection for this patient? Now, let's review in this next segment what kind of data we have and most recent data we have. As you know, Jelena and us published the Checkmate 649 quite for a while. I think the first publication was 2021, so already 3 years ago. Then we have seen the Keynote 859 for pembrolizumab, again in combination with chemotherapy, and we also published the Rational 305, which is the worldwide phase 3 trial for tislelizumab. With regard to responses, you can clearly see that irrespective of the checkpoint inhibitor, there was always an increase of responses with chemotherapy plus IO, particularly 60% versus 45% in the CPS5 or higher for nivolumab, and around 60% also with CPS10 or higher for pembrolizumab, and for tislelizumab CPS1 or higher 48 versus 41%. With regards to the hazard ratios, you see here also in the slide that they were quite remarkable positive for the PFS and also for overall survival. And we will go a little bit more into the details for the CPS scoring. And here you see the slide for the Checkmate 649, the 5-year follow-up. We have shown at ASCO GI, Jelena did it, and as you see here, we have never seen so positive signals and positive survival times. 17% of all the patients survived after 5 years. And this is really remarkable. I think this has never seen before, and we have to think about the checkpoint inhibition really for all our patients in that regard. And this is also true for CPS1 or higher, even higher for CPS5 or 10 or higher. I think this is clearly clinically meaningful improvement of overall survival with nivo plus chemo versus chemotherapy alone with longer follow-up. Okay, and together with the colleagues in Japan, we also analyzed what about the depth of response, the deepness of response. You might remember that in colon cancer we have nice data for Erbitux. And here you see the depth of response. Patients who have response for more than 80% or from 50 to 80%, they have quite an excellent 5-year survival of up to 50%. This is really, we have not seen that before. Indeed, also with chemotherapy alone, it's much worse than what we have seen here in CheckMate 649. 859 was the first-line trial with pembrolizumab plus chemotherapy. It again showed improvement of survival for the same indication as you see here on the left side, overall survival, on the right side, the PFS. I would say it's very similar data. As you see here, nearly 30% had 2-year survival, and this is remarkable again. The PFS after 2 years is 18%. So nice data, similar to nivolumab. And here are the subgroups. And as you see, particularly for the CPS patients, CPS 1 or higher had highly significant benefit, and also the PD-L1 CPS 10 or higher as well. We don't have data for PD-L1 CPS 5 or higher, which is, of course, a question which has been raised by the FDA as well. Now we do have also the trial for tislelizumab, and this was done with a so-called TAP score. At the end, it is very similar to CPS. CPS is a specific cell counting, an individual cell counting, and it's time-consuming for the pathologists. However, the TAP score is a visual estimation of the tumor area. So for pathologists, it's much easier to do TAP scoring compared to CPS testing. You also see that in both scoring systems, we have the tumor cells and the immune cells integrated. Now, here is the rationale 305, tislelizumab plus chemo, again in the same indication. You see, again, after 2 years, more than 30% survived, and it's again similar to nivo and pembrolizumab. The toxicity for tislelizumab seems to be maybe a little bit better than nivo, particularly in grade 3 and 4. However, so far it is comparable. Now, what about the TAP and CPS? What we also analyzed in a meta-analysis with different publications, you see here the TAP scoring 5 or higher has a clear improvement, and it's very similar on the left side, the TAP score, on the right side, the CPS score. Particularly if you go for the 2-year survival, with TAP it's 38%, and with a CPS score, it's 39%. So it's very similar. And the FDA approved tislelizumab for first-line with locally advanced, unresectable or metastatic junction or gastric cancers in adults who express PD-L1 or higher. Now, and particularly with this question, TAP score versus CPS, we did a concordance study, as you see in these rings from the left to the right, from TAP scoring versus CPS scoring for 1, 5, or 10. There is an overlap, and on the left side you see the concordance again, which is in green, quite good for comparison TAP versus CPS. I think this Cohen's kappa data is quite impressive, and therefore I think that many pathologists will use in the future the TAP score because it's easier to do, and it is already established in other tumor entities as well. Now, what have we seen today? Just the most recent data on LEAP 015, pembrolizumab plus lenvatinib plus chemotherapy. We have seen PFS and overall response rate benefit, but no overall survival improvement, particularly for PD-L1 CPS 1 or higher. With regard to the part 1, the safety run-in was good, and the update part 2 just a few hours ago with the interim analysis showed improvement in PFS overall response compared to the standard of care, and the final analysis did not meet its other primary endpoints for overall survival, unfortunately. Also now available, this is the subcutaneous injections. This is also new to me. I did not know that we have also the approval for the European Union, but it is approved now. Nivolumab can be given, atezolizumab can be given subcutaneously, and it is approved in the US, in the United States, and pembrolizumab subcutaneously is under regulatory review. Of course, subcutaneous dosing is easier. You need only 3 to 5 minutes with the subcutaneous injections instead of 30 minutes IV. You do not need the port systems, catheters, and also you can reduce the infusion chair occupancy in your practice. I think this is really more flexibility for the patients, and also I think it's a step forward for better quality of life of our patients. What about other ongoing trials with immunotherapy and advanced gastric cancer? We have the Compassion 15, we have the EDGE and the STAR trials. Compassion trials are cadonilimab. I think this is the company Akeso, and Dom-Sim is from Gilead. And these trials are running in the US, also running in Europe. As far as I know, they are still recruiting, aren't they? Do you know?
The STAR 221 is done. And Edge Gastric, we're presenting OS already.
So the Compassion 15 was, I mean, some of the
reports
are shown here.
Yeah.
But the other two are no results yet. STAR 221, excuse me, has no results yet.
Okay. Good. I'd like to come now to the adverse events. I think this is the most important part, particularly with immunotherapy, because any organ can be affected. And we should think about side effects. I remember that one patient came to me and he was very tired, and I thought the patients on peritoneal carcinomatosis and gastric cancer, I really thought he has massive progressive disease. But then we tested all the hormones and we found out that he has had hypophysitis, and we treated him with corticosteroids, and he is still alive after 7 years of treatment with Nivo-Ipi in a clinical trial. So I think just you have to be aware that also not only hypothyroidism and hyperthyroidism, and colitis, which is very common, like the skin changes as well, but you also should think about more rarely seen side effects like diabetes, pancreatitis, myositis, myocarditis, and even encephalitis. Now, and it's also important to know that particularly the side effects come at different time points. As you see here, colitis is relatively early. Skin rash is also early, but can be becoming better in a few weeks if you stop or reduce the dosages. Colitis, I think you should stop the IO and treat with budesonide, for example, corticosteroids or TNF blockers. And the liver toxicity comes more or less a little later. Very often you have ALT and AST levels increased, but no bilirubin levels increased. With regard to the pneumonitis, this is mostly after 3 or 4 months, and the endocrinopathies are after 6 weeks mostly, and the nephritis is even later. Again, what shall we do? There is the grade 1 with minimal or no symptoms. In general, checkpoint inhibitor therapy can be continued with close monitoring, with the exception of neurologic, hematologic, and cardiac toxicities. If you see grade 2, then there is mild or moderate symptoms. Then you should hold the checkpoint inhibitor therapy until the grade improves. Consider resuming immunotherapy when symptoms and laboratory values revert to grade 1 or lower. And as I said, corticosteroids may be administered, particularly with colitis. However, if you see grade 3 toxicities, you should hold the checkpoint inhibitor therapy directly, initiate high-dose steroids, Again, this can be given as a tablet like budesonide, or sometimes it's better to do it IV, particularly if the symptoms do not improve. Then you should go for TNF-alpha blocker like infliximab, and this can be offered for some toxicities. And then later on, you should taper corticosteroids over a course of 4 to 6 weeks. With regard to grade 4 toxicities, this is really very rarely seen. To be honest, I have not seen grade 4 toxicities except of the hypophysitis in this patient, and the permanent discontinuation is warranted with the exception of endocrinopathies. And then if the patients are under corticosteroids, you can, and controlled with hormone replacement, then you can reactivate the checkpoint inhibitors. But again, I think as it is mentioned here also, patient education coordination with the nurses and care team is critical to prevent additional adverse events in these patients. Now, here again is the picture of the colitis and the liver toxicities and pneumonitis, and I really would like to highlight again, when symptoms revert to grade 1, you can re-challenge with immunotherapy in the patients, and you should be careful, but I think it is really an option, particularly after colitis or liver toxicities or nephritis. Now, coming back to our Jeremy, aged 58 years, what happened to the patients? What do you think? What treatment options would you consider? Let's talk about that, and particularly with a CPS of 11. What would you do?
Of course, this patient is a very typical presentation, and it's important to note the dysphagia, the weight loss, and the need for a relatively brisk response in this patient if you're going to make his disease better. I think the liver lesions are pretty clear. If you're not certain that they're metastasis, typically I get another imaging scan like an MRI or a PET scan. I don't typically delay therapy to biopsy the lesion unless there's later on a discordant response to therapy, which sometimes we see. I also think it's a bit of an academic exercise to say CPS 11. I think most the pathologists would agree that it's very difficult to differentiate. In fact, if those of you who were in a session today, I think it was very well put by Ronan Kelly that really pathologists can't differentiate, with such degree of granularity, the difference between CPS 7, 8, 9, 10. I mean, it's just... I think overall what we can say is that the tumor is PD-L1 positive. You don't have to wait for TMB or mutation status. In fact, we don't typically have it unless the patient had sequencing and then had, on a surgical sample and then had tumor recurred later on, which is clearly that's not the case. But to put it, this is a very typical case in the clinic, HER2 negative, low TMB with PD-L1 positive tumors. So we would do first-line immune checkpoint blockade. The question comes up often, which immunotherapy to use? I usually decide what chemotherapy backbone and the schedule I want to employ for HER2 negative versus HER2 positive. And, with FOLFOX every 2 weeks, the schedule lends itself well. So then it's typically Nivo.
And Pepro can be given every 3 weeks?
Every 6 weeks for every 2 weeks? Yeah, but the mild grade 1, 2 annoying immune-related adverse events, in my experience, is slightly higher. More joint pain, more rashes, mild things that you and I may not be worried about, but it makes the patient uncomfortable.
So I absolutely agree. In Europe, we would also do FOLFOX. Xelox is not so often used. I am also personally, I like S1 because it's also approved in Europe. So we can do SOX. I don't know whether this is also available in the US due to the FLEX trial.
This is not an option. We don't have S1 in this country.
I find every 3-week dosing is too toxic anyway. I think with Capox, it's tougher, especially. This patient is probably relatively fit. He's 58, but I doubt that he's going to be able to swallow all the capecitabine, given our environment here, the simulation.
Okay. Now, I also would like to highlight that this patient had only 2 metastases. And particularly in Europe, we have very strong and active surgeons. And we have been discussing with them the situation of oligometastatic disease. And we have a so-called OMEC consortium in which we did retrospective studies whether the patients benefit if they have less than 3 liver metastases for liver resection, for example. And there's also data on lymph nodes, and also you might also know the Renaissance trial, which was unfortunately negative. However, I think there is still a signal that you can do it, particularly if patients respond very well. And usually we treat the patients for more than 4 up to 8 months. And then if there is something left, then we in our multidisciplinary tumor board, we ask the surgeons whether this is resectable or not. Here you see the real-world outcomes for oligometastatic esophagogastric cancers. They did benefit with regard to overall survival probability, but again, this is retrospective studies, and therefore, I think there is some data on it, but we should be careful. We cannot recommend it, but particularly for younger ones, we would do it. I don't know whether you do it in the US as well.
I mean, I think selected cases sometimes we do these things. You know, at the moment it's you know, it's still outside of the standard, but selected cases, of course, we would consider these kind of approaches.
Okay.
Switching gears is this year we have data emerging both from the Matterhorn study and, of course, Checkmate 577 updates that you saw today. So this is a case of a patient with 65-year-old woman with 3 months history of worsening dysphagia and anemia. She was diagnosed with stage 3 GE junction adenocarcinoma and has good functional status. She wants to incorporate immunotherapy options with combination of with surgery, and actually MSI was found on her testing. So this is an MSI tumor, stage 3 gastroesophageal junction, appears to be resectable but quite symptomatic. And what would be the options for Kathy that you would offer? Would you consider primary resection, which in her case probably would need an Ivor-Lewis esophagectomy? Would you consider adjuvant, neoadjuvant immunotherapy as the standard or clinical trial? And what factors would help you guide this decision? Zev?
Yeah, I mean, I think that, you know, certainly this is a patient where we want to incorporate immunotherapy. Obviously, tomorrow, Dr. Janjigian will be presenting practice-changing data that will apply to this patient. Suffice it to say, I will encourage you all to be there. But that's my intent after seeing her presentation, would be to incorporate durvalumab into this treatment. And hopefully you're all there to see the fine details.
Would you give FLOT, or do you think that's
I think
overkill?
I try to give FLOT if the patient can handle FLOT, and
Yeah.
I think that's still level 1 evidence. I think we all know FLOT can be challenging, particularly in the postoperative period, but
Yeah.
I think we'll see tomorrow that, you know, pretty good job overall.
Yeah, I mean, I think you're right. The MMR-D tumors are not all the same. With the data that we see in gastric are quite different in perioperative setting for IO, chemotherapy-free backbone, just because there's quite a bit of heterogeneity. So in this case, I think, you know, I would also err on the side of doing chemo plus IO. Why is immunotherapy important in surgical setting? We know that something more than surgery needs to be done, and the options are to do surgery, then followed by adjuvant therapy. Of course, chemoradiation is still an option for squamous cell cancer, but is increasingly has been sort of demonstrated not to improve survival in adenocarcinomas. And you know, the FLOT approach has really been more mainstream and standard of care in Germany and in Europe in general, while, you know, adjuvant therapy is more preferred in Asia. So we know that for high-risk tumors, considering anything T2 or above and not node-positive disease, ideally you would do perioperative therapy, because in the United States and North and South America, we mostly have proximal G-junction tumors, and it's very difficult to administer a therapy after complete total gastrectomy or Ivor Lewis esophagectomy, for example. So after surgery, chemotherapy delivery can be quite challenging. Less than 50% historically completed all standard therapy. And what if there were FLOT or perioperative chemotherapy non-responders? What to do for a patient with persistent T3N1 disease, for example, despite chemoradiation or chemo, that's what was the question of Checkmate 577, to try to see if adjuvant immunotherapy can be administered to improve outcomes. Certainly, there's some data to suggest that radiation can induce immune effects and sort of the PD-L1 overexpression goes up over time. I'm not sure how relevant this data is if you remove the tumor, and so I wouldn't put too much sort of academic or what's the word? Your hypothesis should not be sort of surrounded by it, but nonetheless, it's interesting. So 577 certainly is the first data that showed that micrometastases can be positively treated or impacted by immunotherapy. You can induce a second immune response, or you can induce your immune response after surgery. And the Checkmate 577 data looked at disease-free survival. As you can see here, hazard ratio is 0.67, for nivolumab versus placebo. And these were patients that you and I would consider high risk. They all received chemoradiation, typically with carbotaxol, and then after surgery had node persistent or T persistent disease. So the only sort of major flaw with the study is that adeno and squamous patients were enrolled together. And of course, carbotaxol works quite well for squames, but not so well for adenos. And also, obviously, radiation is, squamous cancer is historically much more radiation-sensitive disease. That being said, there is a survival curve separation and sustained separation in the survival curves, although we didn't hustle enough to include the follow-up survival curves. They don't look like this for OS. There is some collapse in the curves. At disease specific micrometastasis or metastasis-free survival, the hazard ratio is 0.71, which is still meaningful, and it once again favors nivolumab and suggests that, of course, these are high-risk patients. We know that node-positive patients are very likely to recur within a year or 2 years, and the survival in that population, is less than 50%. So we really need to improve on that. So looking at the update from ASCO, and I encourage you to download the slides and look at the survival curve, but median DFS certainly was doubled, essentially. And although the OS numerically was improved, this difference is not statistically significant. It crosses 1. So I would interpret this as a negative study. In intent to treat population, it was, certainly in PD-L1 positive population, there is clearly a benefit, as you will see with subgroup analyses, but it's a little difficult for me. It was difficult for me to make any determinations from the subgroup analysis because it's underpowered in multiple ways. One, it's both adenos and squamous, and within adenos and within squamous, the PD-L1 overexpression doesn't mean the same, right? So you're basically, if you were to draw, those circle diagram, there would be too many circles. It would be similar to the diagram of that Zev had, for the biomarker. It's just too many overlapping time points to make a determination as to these subgroup analyses are not clear. But we know it's doable, it's tolerable in adjuvant setting, and so if you have a patient for whatever reason, who did not get neoadjuvant therapy with immunotherapy after, tomorrow, you could definitely consider doing adjuvant therapy. That would be my takeaway. The other reason why Checkmate 577 is not so relevant anymore is because you should really not be radiating patients with adenocarcinoma. If you get anything from me today, do not, radiation just does not add to survival. There's been 2 phase 3 studies just in the last 6 months published in New England Journal of Medicine saying that radiation does not add to survival. And I understand the microclimates of DMTs are hard to disturb and the habits are difficult to break. But if you're a clinician, that's one thing you need to really understand. You need systemic disease control, and fluoropyrimidines are better than carbotaxol in this disease for adenocarcinoma, and that's why CROSS is not relevant. And this ESOPEC study demonstrated that survival is improved with FLOT versus CROSS. At 3 years overall survival, 5 years overall survival, the survival curves separate early, and there's a sustained separation in survival curve. FLOT regimen, which is a fluorouracil, docetaxel, and oxaliplatin. For PFS as well, there's updates of this data basically that shows the same. 585 was a doublet chemotherapy trial, CAPE-CIS, plus pembrolizumab, also done in perioperative setting, similar to Matterhorn, but there's multiple issues with the study design, mostly because of the statistical design, but also chemotherapy backbone and so forth. And although the interim analysis of pathologic complete response was reached, with 12.9 path CR in the pembrolizumab arm, with a delta of 10, it did not translate to positive study. And the event-free survival curves do separate, but the alpha was split between EFS and OS in this analysis. And because the EFS did not hit on significance, they couldn't pass any alpha to OS. But even if they did, you could see these curves are essentially OS curves overlap. So even though EFS curves separate, the OS curves do not. So why is that? I think most of it is related to the design, the population of patients, but the cisplatin backbone. Tomorrow, 3 o'clock in the plenary, you'll see this data with FLOT. It's a global phase 3 study, and probably the most well-represented balanced population to date in the perioperative setting, or really any study in terms of admixture of Asia, North, South America. And durvalumab was combined with placebo or with FLOT versus placebo with FLOT. And in this study, as you see here, the path CR rate for the FLOT group is better, 19%, and the delta is slightly more, but not by a lot, maybe by just a couple of digits in the central review. The near pathologic complete response is improved. The big question, will it be translating then to EFS and OS? But you'll have to. That we will talk about MSI, and of course it's a specific population of patients. Neo-Nipiga shows that dual immune checkpoint blockade is helpful in those patients, but the responses are not 100% in the same way that we see it in, for example, rectal cancer. So I think to Zev's point, chemotherapy is still important even for MSI tumors in this disease. We do have data that maybe prolonged treatment is important, 6 months, but I wouldn't rush necessarily to just doing single-agent anti-PD-1 in these patients. But Neo-Nipiga demonstrated this is a unique patient population. I think organ preservation is within reach for these patients. It's just surveillance for residual disease is a little tricky. And Infinity is a similar trial as well. So let's revisit Our Lady. The question is, how would you proceed with this case? Would you do chemoimmunotherapy, immunotherapy alone, chemoradiation? How would you survey her for pathologic complete response? and what is the role of liquid biopsy in this? Marcus, maybe you could tell us.
I mean, as you already showed the Neonipica data, and we also have data from Italy with very similar results. So I would really say, I mean, we also have the Dante trial in Europe, in which we have seen that even in the MSI, FLOT is doing very well with increased pathological complete regression. I mean, at least for me, in Europe, we do not have the approval for checkpoint inhibition. So sometimes in our tumor board, we say if a patient has a stage 3 disease and the lymph nodes are so nicely spread, then we can say it's like a metastatic disease. and then we say to the insurance company, the patients cannot be operated, and we treat them with like a palliative first line. And then they get, of course, chemo and IO, and then out of a sudden, 3 months later, patients can be operated. So this would be our way to circumvent, to give the patients the checkpoint inhibition.
Great. And ctDNA, do you use it routinely in your practice?
No.
So we had a study actually just less than 2 weeks ago presented here at ACR showing that ctDNA is very useful in MSI tumors for MRD setting. But I do think you have to be very careful with these assays outside of clinical trial. We demonstrated that you can clear ctDNA with adjuvant pembro, you know, it's predictive, certainly, of outcome and prognostic, but this was a single-arm, non-randomized study. It was actually impossible to do a placebo-controlled study. We had to close the placebo arm. So we have the approval for MSI patients with pembrolizumab in second line, but not in first line. So, so it's the same for you, or? For MSI, or for MSI, I mean, you could use IO in first line. Okay. So. HER2 alterations in gastric cancer. HER2 was the first validated target in metastatic disease. Up to 20% of tumors in the stomach and 30% in GE junction overexpressed this biomarker. We use immunohistochemistry, and of course you use FISH for IHC2 plus patients. There's quite more heterogeneity in gastric cancer than in breast cancer. So if you do NGS, next generation sequencing, you may actually, you know, a lack of amplification on NGS when you have a focal positivity on IHC is actually somewhat predictive of survival and PFS on first-line therapy. So NGS may be useful from that perspective, and also from co-occurring alterations which drive resistance. So the typical way that we test it is, and the quickest way in first-line setting, for gastric at least. For colon, it's slightly different, but for gastric, it's IHC first, followed by FISH. And then, you know, we also order sequencing, again, for these other points that I discussed. And the ctDNA using tumor-informed analysis in specific cases may be helpful to monitor for loss of HER2 and trastuzumab or T-DXd resistance. ADCs have been really entering strongly into this field, and in gastric cancer in particular. Historically, you know, approaches that worked well in breast cancer have not worked so well in gastric because of the difference in the disease biology, co-occurring alterations, chromosomal instability, and really the drivers are quite different. But we've had some successes with dual immune checkpoint blockade with anti-HER2 therapy. The lapatinib, neratinib, tucatinib stories have been kind of not so straightforward. And T-DXd obviously has been really the main major breakthrough for second and third line therapies, reigniting the interest in trastuzumab resistant tumors, and hopefully now we're moving it to first line. The first line HER2 space is becoming quite full. Of course, we have KEYNOTE-811 with pembro-traz, but also now zanidatamab is coming into the market, and other bispecific or biparatopic antibodies that are sort of, you know, being developed as a really more effective way to inhibit HER2. historically, inhibiting HER2 in a more complete way with traz, lapatinib, or trastuzumab, pertuzumab has not worked for our disease. But I'm hopeful that some of these newer agents may be able to change the landscape, because these patients are living longer and we need more help. So the TOGA study is what brought this target to us, and this has been over 12 years ago now. But this is what our benchmark has been: median OS of 13.8 months, and this was in FISH-selected patients, so they selected by FISH first. So if you look at modern way of selecting patients by IHC 3+, IHC 2+ FISH positive, as opposed to starting with FISH, where IHC 0s sometimes are in that cohort, that number, the median OS, goes up, closer to maybe 14.8, 15 months. So, you know, but look at this nice separation in the survival curve, even for that, you know, older study, but they do start to come together. So we know that IHC is probably the better biomarker, and it's not really a better biomarker per se, but I think it's a better biomarker of homogeneity. So perhaps, you know, because it has to do more of the staining than the actual biology, and it's cheap and it's faster, and you can use it in first-line settings. So start with IHC first. And then, of course, KEYNOTE-811, after a decade of negative studies, again, as I mentioned, pertuzumab, T-DM1, lapatinib, went the other way and combined it with a anti-PD-1 therapy with pembrolizumab, because the rate of PD-L1 overexpression actually goes up as you are treated with trastuzumab as the mechanism of ADCC escape. And we were able to sort of break through this inertia and change practice with the updated overall survival published as a letter in New England Journal of Medicine, so you could read that. But you know, overall response rate was improved, PFS and OS. So now the benchmark for pharma to improve on is the median OS of 20 months. With early and sustained separation in the survival curves. And the reason why I pointed out the survival early on in the TOGA study is because look at the median OS in the control arm here with the placebo. It's performing better. And that makes me happier, because that means we're taking better care of our HER2 patients, right? We're using modern oxaliplatin-based chemotherapy. We're selecting patients for therapy in a better way. Perhaps we're dealing with toxicities better, and so they're getting better as well. Of course, response rate there was some attrition from phase 2 to phase 3. In phase 2, we saw at MSK, IST, 100% disease control rate with 91% response. Here we saw 72.6% response, which was good for a phase 3 study, and actually let us get interim approval based on interim analysis for the FDA. So we've been using these agents in the clinic for quite a while. And as I mentioned, the landmark survival is at 3 years for this disease is improved. So the caveat was something we were surprised by, is that most of these tumors are PD-L1 positive. And what we see is that PD-L1 positivity, at least in these subgroup analyses, was important, because the hazard ratio and the outcomes for PD-L1 negative patients were not as good and not as straightforward. Although every time we update the data, the hazard ratio seems to be decreasing. Nonetheless, going along with the same trends as in HER2 negative disease, now the FDA and the EMA restricted use of pembrolizumab, trastuzumab for CPS greater than or equal to 1 patients, which certainly will be difficult for future drug development and comparison arms. And, when you have to exclude a rare population of a rare population, from a trial, ends up being not good. So what I do typically, if I have a HER2 positive case that's PD-L1 negative, which I've only had one in my entire time testing it, I just retest it. And in the case that happened was actually the node was completely replaced by tumor, so there was no stromal component for the pathologist to test. And when we tested another sample from the same time point, the PD-L1 was actually 6. So it's an important lesson to know. As you continue anti-HER2-directed therapy, the baseline, resistant mechanisms, which is p53 mutations, chromosomal instability, EGFR, MET alterations, just get worse over time. And then also the tumor loses HER2 expression, as this is an old paper of ours, proving that, demonstrating it simply in a case of a patient who, I was going to put on a single agent anti-HER2 study as a, naive early investigator, and obviously this patient would not have responded to a trial. But how do we drug those tumors after trastuzumab resistance? Luckily, T-DXd was developed, and this is a antibody-drug conjugate with a serious chemo attached to it. This is no joke. If your patients think that this is some light targeted therapy, that they're going to be unpleasantly surprised. There's chemo side effects associated with it, but it is a game changer because it brought back the possibility of targeting HER2. DESTINY-Gastric 01, of course, was the first study. And what's interesting to see is how the responses, no matter what T-DXd study you see, are almost identical, right? Look at 01, 02. Today you saw 04, which is, Kohei presented at the oral session. So the response is in the low 40s, which is good. And this appears to be irrespective of line of therapy. Again, what does that mean biologically? That means there's a cohort, the same group of patients that probably benefiting to this drug, and it makes sense to treat them early because you're going to lose them if they deteriorate and never get to get to the drug. So the way I prioritize these options, and today, of course, you saw DG04. I don't know if we have showed that in second line randomized against Taxol ramucirumab, you have a survival benefit for T-DXd compared to Taxol ram. Median OS of 14.7 months. This was all ex-US study, of course, because the FDA approved T-DXd. I actually wrote the study and we couldn't even open it in US because US T-DXd approval just happened so magically after Gastric 01 opened, was read out. But the hazard ratio for survival is 0.7. Overall response rate, as I mentioned, 44. So the way that I would think about it is after initial failure of pembrolizumab and progression, rebiopsy the patient if it's safe and feasible. And if the tumor is HER2 positive, that's the one I would go with T-DXd. If the tumor is low or negative, perhaps go with some other options, maybe a claudin inhibitor on study or something else, Taxol ram if you really have nothing better to do, and then use T-DXd in third line. So, of course, everything is always moving. This field, we are in it for the change and the improvement. So Gastric 03 is a complicated study that led to basically dose finding and MTD and preliminary efficacy of how to bring T-DXd to first line for HER2 positive disease. The reason why we want to do it is because it's a platinum-free chemo and also offers patients this bystander effect. Because of the heterogeneity, you are able to perhaps affect the HER2 low or negative clone in the same area as the HER2 positive clone. And you have to combine it with capecitabine, of course, or fluoropyrimidine if you bring it to first line, and we did that. And we also used immune checkpoint blockade with pembrolizumab. So 05 is open, started to accrue patients. We just put on first few patients, so far so good. And we'll be updating the results of the 03 study at hopefully in a future Congress. So practically, T-DXd, as I mentioned, is you have to be ready to deal with nausea, fatigue, neutropenia, and of course, the main side effect that everyone worries about, especially from what the data we saw in breast and lung, is interstitial lung disease. The trick with ILD is you really have to pick it up at grade 1. You should look at the scans, you should read the report in entirety, and if you see any mention of ground glass opacification or something in the APCs that the radiologist is referring to, non-specific inflammation, because the radiologist doesn't know the patient is on T-DXd, look at the scan and, perhaps hold the T-DXd and send the patient to a pulmonologist if you're not sure. I think if you have any symptoms, dry cough or anything like that, you would have to probably start steroids. But if you catch the ILD early, it's really not a problem. Shouldn't lead to any major adverse events or grade 5 events. And I don't typically get any extra scans because we scan these patients so often anyway. You will pick it up if you're careful and read the scans. So the progress in validating HER2-directed therapies has been really tremendous, and other emerging agents are, on the horizon, as I mentioned, including newer HER2 ADCs and enzalutamide, which is bispecific antibodies, and perhaps, targeted other cellular therapies. So let's go back to our case. This is a 65-year-old patient with mild dysphagia. On endoscopy had a tumor and liver metastasis, and the tumor showed that it's PD-L1 positive, HER2 positive. So, Zev, maybe I'll ask you, what would you do in this case?
Yeah, pretty straightforward case. I think falls within the exact framework of what we would expect to get with FOLFOX, trastuzumab, Pembro. So no dispute there about the CPS score, so that would be my preferred approach.
And so do you dose Traz every 2 weeks?
Yes, I do. I think that's where sort of we did it in the early days, and that's where we're continuing to do it. And, I think that it's a regimen that, even though Capox was mostly used in the KEYNOTE-11, I think we've adapted to it pretty well. So, whether you give the Pembro every 3 weeks or 6 weeks, that's kind of up to individuals. So.
And Marcus, what's your go-to for HER2-positive tumors?
It's the same. We have the approval according to 811. We would also do FOLFOX, trastuzumab, pembrolizumab, of course. And since this is, again, a patient with oligometastatic disease, we would treat him for, let's say, 6 months. And, we see great responses. As you showed in your publication, 75% have clear responses. And we see that in the clinic also. It's really great. And even with brain metastases, we see excellent responses. And I think this is the best regimen we so far have for gastric cancer. Of course, it's a biomarker-driven disease. And I would clearly say after 6 or 8 months, we could reduce chemotherapy if they respond, particularly reduce oxaliplatin, that they don't have so strong neuropathy. And again, if there's something left, we would operate on the livers.
What would you do? And I think, this is something that I've encountered a number of times, and I'm curious what you guys think. And someone has a CR. I've had a number of patients have a CR after 6 to 9 months of chemotherapy, and I reduced the chemo, and now they're on maintenance Pembro Traz, and I'm not sure when to stop it. I'd like to stop it all, of course, but we don't really have data. I'm curious what, because this happens, as I'm sure you've seen it a bunch, Elena. So how do you approach those patients?
Yeah. Well, we've been giving this regimen since 2016. So we scope them regularly. Endoscopies, I think, are very helpful. I typically don't operate on these patients. In fact, well, not me, but in general, our DMT. In fact, the few cases where we took the primary out because of worry for persistent disease in that area and bulky disease, most of these recur. When do they recur? It's variable. Maybe you buy them some time off therapy, but they recur. So I've sort of my pendulum swung against surgery and
do you stop treatment ever, or you just
it's
keep them
hard
on?
to U.S. patients are very they're just if they don't have any talk. I have a patient in my clinic. I just saw him last week. He's been on this regimen for nearly 5 years, and he just cannot stop. He won't
the challenge
stop.
is trastuzumab also, right? It's hard to dose it less frequently than 2 weeks. Right?
Well, I go with every 3-week dosing in Pembro, and then I put him on CAPE, And yes, we watch their echoes very carefully, but realistically, in our disease, EF stays the same. And, it takes me longer to have this discussion. Our discussion mostly focused on me trying to get him off treatment. And he, so it's a bit of like, it's funny, but...
No, it's a good problem to have, and it's certainly great that we have even these cases to discuss.
For MSI cases, the way I sometimes talk the patients into stopping is ctDNA. And if their ctDNA cleared and the PET is completely negative, after years, usually I'm successful at stopping, getting the patients off it.
So at least in Europe, we do have some kind of recommendations, particularly for melanoma, that you should not treat patients for longer than 2 years with IO. And then, therefore, we would say at least after 2 years of pembrolizumab as maintenance, we would stop. That would be...
I say the exact same thing to my patients. I think it's tricky. I have a MSI patient who's a physician and understands, but he had peritoneal disease and he's very scared, and it's literally been 6 years. Yep. He won't let me stop.
It's a big part of our time now we spent, actually. So in your case, Elena, here's the progression that inevitably occurred.
Yeah.
I guess we all feel now, especially based after today's data, would we rebiopsy the patient, or do we feel good enough about the or ctDNA, or should we just treat them with T-DXd?
I typically rebiopsy. These primary tumors are in place. It's relatively easy to get to, and unless there's a medical reason not to rebiopsy, I think you should, because it'll first of all give you a sense of how likely he's to obstruct what's going on in the primary tumor, but also give you valuable information about his biomarker. What if he's HER2 negative but has a claudin expression?
And so you trust the biopsy when you do it. It's
ctDNA
HER2 is not like
trust.
PD-L1. It's a little more
ctDNA
robust.
I don't trust because none of these ctDNA assays were designed for amplifications.
But you lose in 30%. You lose
the
HER2 expression.
To the point of and we didn't. It's a shame the presentation was so quick today. A lot of us really wanted to see that granularity about how many patients had either positive biopsies at progression, how many had ctDNA. I think a lot of that data will come in the months ahead.
At post-progression? I mean, everybody, but to get on
no,
DGO4.
at baseline, yes, but I mean, how many of these patients kept being HER2 even after
Oh,
T-DXd?
well, that's not a primary paper. That's TBD.
So it's quite interesting for me that you do the ctDNA. So, I mean, can you really organize the treatment according to ctDNA? I mean, we don't have any clinical trials on it. Why do you do ctDNA?
For which disease?
For like here.
I said I wouldn't.
You wouldn't.
It's exploratory. It's really only exploratory.
I think that was an option, but amplifications are just, I mean, look, if you have an amplification, we've showed that it's predictive. If you have a baseline amplification, you'll actually do very well on pembrolizumab. But if you don't have it, it doesn't mean that maybe we missed it.
So here you go. We did the right thing. We biopsied the patient. They're HER2 3+. Now, after today, I think we all feel pretty good about recommending T-DXd. We all agree. Especially because you can tell she has a cold and she has a big day tomorrow, so at the end, we'll let her leave quickly so she can get some good night's sleep. Okay, so I'll talk quickly about Claudin 18.2 and future directions. This is a very different kind of biomarker. It's a non-oncogene, so it's more of a lineage marker. We've known about this for almost a decade now based on some early phase 2 data, and now we know obviously a lot more. What do we know? We know that it represents a membrane family of tight junction proteins. We know that it's highly expressed in normal stomach mucosa and even in some small intestinal mucosa. We know that it's very common in gastric cancer, depending on what cutoff you use, but 70 to 80% of patients have at least 80% I would say, have some element of being positive for Claudin 18.2. And pancreatic cancer also represents a high-frequent cancer with a lot of Claudin 18.2 expression. Now, there have been a number of pre-screening studies over the last number of years, which are really very, very large studies, which have really give us a good sense of frequency. And I think this has all come to light in the last few years, so it's really impressive how quickly the field was able to put together these pre-screening efforts. And here you can see we're talking about a disease that has 38% and probably 38 to 40% using the cutoff of 75%, which is the registrational cutoff for zolbetuximab, of course. And of that, about 17 to 20% probably have CPS greater than 5. So there's some overlap, and that's obviously a big topic of discussion and of interest. Now, there are a number of ways to target claudin. The gold standard is zolbetuximab, which is a monoclonal antibody. We'll talk about the data led to that approval in a moment. We saw today, and this is something that we've never seen before, and I don't even know quite what to make of it yet, but we saw a randomized phase 2 trial, I believe, of this Carsgen CAR-T, which we've heard about for a while now, compared to chemotherapy in claudin 18.2 positive, which did show, if all was to be believed, a progression-free survival advantage. Very challenging to interpret that data, and I think we all have to really take a step back before we consider that a positive study. But still, I have to say, to have a randomized study in solid tumors in CAR-T is gastric cancer is the first one. So keep in mind 95% grade 3 AEs in that trial, by the way. I thought that was we didn't spend enough time on that trial in the discussion, that's for sure. Anyways, bispecifics are all the rage. We know about this throughout cancer, and certainly claudin 18.2 is no exception. There's many ways to make a bispecific, many T-cell areas, T-cell modulations, and many others. All of these trials are in phase 1, some of them in phase 2, and of course ADCs, which are, of course, many are already in phase 3 development for this disease. So the 2 pivotal trials for zolbetuximab, both of which have been published in the last year or 2, are Spotlight and Glow. One Spotlight with FOLFOX, one Glow with CAPOX. Spotlight predominantly in Asia and Europe, zolbetuximab in China and Western Europe. So a little bit population differences. That's why you may see medians be a little different. Overall, both of them really showing a statistically significant improvement in overall survival in the group of patients who got zolbetuximab plus chemotherapy or over placebo chemotherapy. This was also updated recently, combining the 2 data sets together. There is a consistent improvement in both of them, about 2 months of median PFS, about 3.5 months of median OS. Data holds up very nicely along that, along with obviously the nausea and vomiting frequency, which is a class effect, of course, of all claudin 18.2 targeting agents. We got in this satri-cel, which did show, I don't know if it showed an overall survival advantage. I think that to me, the overall survival was trended, and it was a very problematic Kaplan-Meier curve in my view. But progression-free survival, which I assume was investigator assessed, I don't know. They say it was IRC, I'm not sure. But long story short, a couple months, it's a lot to ask. And I think that for my first instinct on this, for a 1.5 median progression-free survival to have a 90, look at the difference in the grade 1 to 2 CRS, 95% toxicity versus chemotherapy. We didn't even hear the details of the chemotherapy, what they got. So this was a snapshot maybe, and perhaps we'll see more of this in the years to come. But I think proof of principle is important, and I think they showed that to some extent you can do that. Yeah, go ahead, Mark.
I mean, it's just 2 months benefit. It's even if it is third line, but it's a huge amount of money you spend, and a lot of side effects with the CRS, 95%. I think this is really high toxic.
No question. And
yeah,
Yelena,
I think the discussion, and I think what I want to see, and I was trying to see, but from what I saw on the survival curve, there was not a single cure. Even if it was one patient that we cured, or gave them a meaningful year or 6 months, I would say it's worth it. For at least my interpretation from the survival curve that it was a drop.
I noticed that too. There's no tail there, and
so I think if I was this CEO, I would kill that program.
Yeah, I mean, parenthetically, I think some of us know the program did try to find its way to these shores and ran into some problems in the United States. The cost, the patients progressed too quickly. The so-called bridging therapy is problematic when you're trying to lymphodeplete people. They have to be admitted to the hospital. You can name the number of problems in which this is practically challenging. It is nice to have a proof principle in this disease. So I think we don't look at this as anything other than proof principle. And the next company,
I don't think the principle is even proved. I mean, it's...
Well, that you can induce a response.
I think the only we've proven is that I
response.
can't believe we're even giving these therapies. I mean, the control arm did terribly.
Yeah.
So
I mean, that is our control arm, the
yeah.
investigator's choice. We didn't hear the details about that.
Yeah.
Anyways, that's our unfiltered opinions up here. Okay.
It's getting late.
Okay, yes, FGFR2, and so this has been around for a while. Some of us have a big interest in this. We have data for bemarituzumab. We have data for futibatinib. Single agent doesn't have much activity. Expression probably represents 25 to 30% of the disease. If you go higher and higher with the cutoff, the expression level decreases, or the incidence decreases. So what do we know? We know that bemarituzumab had activity and PFS advantage in the FIGHT trial, which was a randomized phase 2 trial, which was placebo-controlled. We are, of course, now waiting for 2 phase 3 trials, and they're both ongoing. Both of them will be resulted and reported, we hope, by the end of 2025, unless something really crazy happens. So both of them are unknown at this time. So targeting EGFR, c-MET, this is of interest now too. I think years ago we played around with c-MET antibodies, and you know, I remember from those days, and you know, they failed in the overall survival endpoints. But now we have these new MET ADCs and EGFR ADCs, and they're actually active in gastroesophageal cancer, some of these antibody-drug conjugates, whether it's because they're working in MET-positive disease or not, or it's a bystander effect, we don't know. But certainly this, you know, this new wave of drug development in antibody-drug conjugates has allowed us to re-explore these targets in this era. So we hope to hear more about those drugs in the future. It'll be very interesting to see, actually. Finally, our final case is Jonathan, a 7-year-old patient with metastatic gastric cancer. His molecular profiling, he's got diffuse metastatic disease to the lungs. His metastatic profiling reveals HER2 negative, CPS less than 1, but Claudin 18.2, who just makes the cutoff of 75%. How would we treat this patient with a CPS less than 1 confirmed on 2 separate biopsies, markers to be CPS less than 1? How would you approach this patient selection?
Zolbetuximab, of course.
Zolbetuximab.
Yeah, I just have to mention that zolbetuximab was developed at our university clinic by Ugo Sain and Özlem Türeci. They also developed, as with the company BioNTech, the vaccine against the COVID. And at that time, we had actually in the phase 1 and the phase 2, we had the difference between the operated and the non-operated ones. And there is some kind of ballooning, and you have to be aware, if you do a CT scan after the first 6 weeks, some of the patients who are not resected, they might have a progressive disease. It looks like progressive disease in the stomach, but it is not progressive disease. It's some kind of ballooning. But I would really I'm very much in favor of zolbetuximab plus chemotherapy according to the spotlight.
Yeah, I think I agree. And let me ask you then, in light of your experience, then how do you handle this nausea, vomiting?
Yeah, I mean, in the beginning, the company said there is some immunogenic effect of the zolbetuximab, and they did not allow us to give corticosteroids. But nowadays, I think you can nicely use the corticosteroids. There is no interference with the activity. So I would give dexamethasone, a classical antiemetics, and also what some of the patients is good for is Tavor. Do you say Tavor in the US as well? It's olanzapine.
Olanzapine.
So yes. Olanzapine you can give. So and then the patients may sleep during the treatment with zolbetuximab.
Yeah. I mean, I think we're getting more experience. We're throwing the kitchen sink at them. You learn any tricks that really work for you?
Give them Folfox/Nivo.
All right. Yeah. Well, we do wait for that data combination trial. That'll be an important trial. I think that we all are learning, and I think one of the things with any new drug and class is that we're going to learn more in the next few years. Actually, Dr. Shitara gave me I asked him once, what do you do? Because he has a lot of experience over there, and he gave me like a whole float sheet. It's actually very helpful that I've employed in some of my patients. I do have some questions here, which I will circulate to my colleagues. So, Yelena, the first question is for you. You mentioned, I wonder if you could, there's a question about, that you presented the DESTINY-Gastric 03, and now we're poised to launch, as you mentioned, the new frontline trial. There's a question about the dosing of T-DXd in relation to, is that the question? Or what is the current status of phase 1b DESTINY-Gastric 03? Do you think it could be approved? Well, I think you answered that by saying the DESTINY-Gastric 05 trial, which is a registration.
Yeah,
trial.
03 is not...
phase 1.
It's not designed to be... I mean, it's a large... I mean, there's 40 patients per cohort, but it's not... and the dose is T-DXd 5.4 with
5.4, okay.
750. Yeah.
With Pembro. And the control arm, I think, was on this. Correct me if I'm wrong. The control arm is the Keynote 811.
No, there's not really a control arm. I mean, it's multi-cohort. It's a 6-cohort study, looking at different options. Oh, for
the front line. Yeah, for 05.
Yeah.
Okay.
Yeah,
okay.
Well, Keynote 811 for only PD-L1 positive.
Yeah. Okay. So. There's a question here. I'll ask Marcus. Do you do in Germany NGS for every patient with advanced disease, or?
So usually we do the 500 gene panel only if patients are in second line. So first we do simultaneous testing for CPS, MSI, HER2, Claudin, and in the younger ones also Epstein-Barr virus, EBV. But the 500 gene panel we do if we are in second or third line. Yeah.
What do you do with the EBV information, Marcus?
It's 3% of the patients are Epstein-Barr virus positive, and they can be treated with immunotherapy.
Oh, so you do use that? Oh, interesting.
Yeah.
So some question here. Mechanisms of trastuzumab resistance. So, I mean, this is a whole topic in itself. Yelena talked a little bit about that earlier, and, there's lots of studies showing all sorts of redundant RTK amplifications that usually occur. I think it's a very interesting topic scientifically. I think the reality is that, with T-DXd and, now coming up front with ideas that if it does come up front, we'll have longer durability. But, it won't be an easy study. I think Elena will acknowledge, because the bar is so high. If a median overall survival of 20 months in that PD-L1 positive group, it's going to have to be probably a 2-year overall survival to achieve a statistical superiority. So you got your work ahead of you, Dr. Genjigian. Final question. Marcus, I'll ask you. Heterogeneity in gastric cancer, generally speaking, and in HER2 in particular, is there a way that you think about that, or is there tumor heterogeneity that do you biopsy patients at multiple time points and at multiple organs?
Absolutely. This is a very important point. I mean, we know that the HER2 positivity rate is around 20%. It really depends on the pieces you take. And usually our gastroenterologists do 6 to 8 biopsies. I think that is the minimum you have to do also for the other biomarkers. And heterogeneity is really a very difficult situation also now for Claudin. And all, it's not that strong for CPS, but I think the pathologists should be aware and should test at least 3 different biopsies from the patients, yes.
Yeah, I agree. I think in general, this to me is one of the more heterogeneous diseases out there, both epidemiologically, biologically, clinically, and that's what kind of makes it interesting. And that's something that I think we're all quite humbled by. The disease is really smart, and gastric cancer, esophageal cancer, GE junction, these are in some ways different. We think about them differently. Sometimes we treat them the same, but they're actually somewhat different scientifically. So that's what makes it fun. And I think, obviously, we're happy to be here today. I think that concludes the presentation. We're looking forward to tomorrow's big day, which will be a very important presentation that Dr. Genjigian is giving on behalf of our entire Matterhorn team. And we want to thank you guys for your attention.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, Hope for Stomach Cancer. This activity is supported through independent educational grants from Astellas, AstraZeneca, BeOne Medicines, Bristol Myers Squibb, and Merck Co, Incorporated, Rahway, New Jersey, USA. To access all materials for this activity, visit peerview.com/EHA860.